speaker is Dr. Dennis Gable, who's going to talk to us a little bit about his personal experience in developing a vascular verification program in his system. Dennis?
Thank you, Matt. I'd like to thank everybody on stage, as Dr. Schutz has already said, about inviting us to share our personal experience here. We went through at our institution as a beta site, similar at the same time as Dr. Darling. Our site, we are not a full academic center. We do have residents and fellows. We are a community practice site, so I think that brings a little bit different view for the inpatient side. I have nothing to disclose. I'll try to make this shorter, as I know, as Dr. Eagleton said, we're running a little short on time. The PRQ, which has been previously shown, can sometimes seem a little daunting. And as a site that doesn't have, a lot of infrastructure in place to do these types of things, it can be a little bit difficult to look at that and think what you're going to do. But I would challenge you and say that this is really a journey. It's a constant journey all of us have, looking to improve our patient outcomes and improve our quality, but it's also a journey you're going to get to look at your site and look at your service line. In other words, to go down the path of the vascular verification, you're going to go through an extensive review of your entire service line. That's going to include, as always been alluded to, the the outpatient side, looking at when the patient first shows up in the office, how they're approached, what the discussion is about what types of treatments are offered, and obviously throughout the entire process, does this concur with the guidelines that are recommended through the SVS for vascular care? This also includes, obviously, the preoperative evaluation. Does it include an ERAS program? And if it doesn't, are you in the process of maybe putting that into place? Does it include evaluation for prehab or frailty, as these have all been shown for certain procedures that if a patient can pass that, they may have better outcomes, and we want to identify those that may have worse outcomes because of a low score. Perioperative process, that's looking at the patient from the time they actually come into the hospital, if they're an outpatient, or when they're admitted, looking all the way through the time they get to the operating room, how they're approached from your operative scrub team, your operative nurses, looking from anesthesia standpoint. It's going to go through all of that, and that's how it brings down the pathway or the journey for looking at this. So it also goes through post-operative experience, ICU floor protocols, and the post-discharge, looking at immediate post-operative discharge and follow-up. Is that arranged prior to the patient leaving the hospital? Do they have any imaging set up if that's going to be needed? And what's the long-term follow-up? And are we as providers providing that care that's recommended? So we've seen some process additions at our facility. We've had many order sets that were hardwired, but this, in conjunction with VQI, allowed us to confirm and assure that we are putting all the hardwiring areas into place. And this included dual antiplatelet therapy for those procedures that benefit from that, statins. Are the patients having that preoperatively if they need it, but also postoperatively? So it's not just the fact that they're on it, but are they going home on it, and are they being discharged on it as they should? The biggest thing, or one of the biggest things that we had a change in our facility is a POCMA process. Now many of us that have been around for a while, this would be the same as morbidity and mortality, but this is phase of care morbidity and mortality analysis or assessment. We had this in place prior to our site visit, but in looking at that, actually, one of the I won't say critiques, but one of the recommendations was based on our volume that we perhaps enhance this a little bit, and that is one of the things that we did do. So our POCMA process, which was once a month, now is twice a month for peripheral vascular cases. We also have added a specific aortic POCMA that occurs once a month. This is just for the aortic cases. The reason we split them out is because there's different discussions that happen on both, and our multidisciplinary teams, which I'll get to in a minute, will participate more highly if we can have all the cases for aortic. Our CT surgeons attend all of those, so we get a multidisciplinary view and review of all cases that we do. Cases looking at identified for these cases for the POCMA are identified not only by the physicians, but also by members of our quality department, members of our nursing staff, even our fellows will send cases that they think may be worthwhile for discussion to the PACMA. We have cases that are reviewed prior to the meeting, both by the primary surgeon as well as a secondary surgeon. Both of these will lead discussion during our PACMA process. It's a non-punitive discussion. It's not a peer review. It's purely educational. What this has led to in our facility is a good multidisciplinary attendance. We have not only vascular surgery, but we have CT surgery. We have cardiology colleagues that also participate in our vascular verification assessment. We have our fellows, we have our anesthesiologists, we have our APPs, and we also have nursing leadership, nurses from the floor, and nurses from the OR that routinely attend the conference. Again, a lot for education, but also to see what they can do to help ensure that we are going down the pathway of improving our patient care. This allows us to not only identify the immediate cause, but hopefully identify the root cause, so that as we go forward, we can discuss the entire hospital stay and not just the single event that may have brought that patient for review. Each event can have multiple phases assigned, can be preoperative, postoperative, or both, or even discharge. We can discuss opportunities for improvement and ways to avoid any issues that may have been found going forward in the future. This is a learning opportunity where all attendees can get CME, and it allows other departments to align with us. So the PACMA process has been a very good thing for us, but we've expanded it even further in that we've allowed now that we have a pre-procedure high-risk case presentation. So if someone sees a patient that they think needs to have a procedure that fits within guidelines that's been agreed upon within our section, that patient is brought forward to PACMA before a procedure to get input from multiple disciplines, multiple providers, so that we can hopefully provide the best care for that patient. Multiple service lines improvements have been seen. This has led to initiation of specialized training for staff and physicians, but also specialized nurse teams. Some of these were in place beforehand, but we've been able to go to the C-suite, as is outlined by some of the others, and ask for more resources. We now have specialized nurse teams for not only aortic cases, but complex endovascular, and even for post-operative care, our nurses there. We talked about the high-risk second opinion. This process allows us to focus on the importance of patient frailty. It allows us to focus on prehab. Prehab sometimes can be difficult, but in going to our C-suite, they have been supportive of allowing us to partner this with our cardiac rehab section. So now our patients, not only that have cardiac surgery and go to cardiac rehab, now our prehab patients can also go to the same area, undergo evaluation for prehab, do some walking exercise. We can see how they're doing and get a good judgment and good evaluation for the prehab. This has also allowed improvement of processes for transferring patients for various reasons. Of course, acute aortic transfers, but really for anything. It's allowed us to align with anesthesia to ensure that we're going forward with the ERAS. We've gotten buy-in. This process has helped us get buy-in from all of our colleagues, anesthesia, cardiology, in pursuing the outlined guidelines for vascular care. What this has led to for us is led to a high-risk patient case presentation prior to the procedure that we talked about. But as many of you have approached us and talked about cost, and that some of the C-suites at your institutions are not interested in much except does it reduce my cost, we have in fact seen in the 2 years that we've done this a shorter length of stay. We've experienced cost savings for the facility related to this. We've experienced what I think is improved outcomes. We've also been able to document and have ready for MVPs. I don't know if you know what MVP is. Many of you do, some of you don't. This is the MIPS value pathway. This is the new way that Medicare or CMS is going to be going to us to ask for billing, and that you have to meet certain standards or certain documentation for the MVP. Going down the vascular verification, because of that, we've already met the documentation that's required, because it's a similar documentation that's required with the verification program. So as soon as this goes live, which right now is projected to be 2026, we are already there. So by doing that, hopefully our facility will be able to experience a little uptick in their reimbursement, and therefore we, as a section, can go to our C-suite and ask, as has been outlined already, for more input from for things that we need to drive the service line going forward. One thing that has not been alluded to is branding. This is one of the ways that we can brand our specialty. It is one of the ways you can brand your facility and also your individual physicians. We have a lot of, over the last several years, a lot of members have requested a way to brand our specialty and a way to brand themselves in the area as vascular leaders. And if we're going to do that, we have to have an active participation in a way to get our brand out there. And this is one of the ways, in my view, personal view, that we can do that. Vascular care is a team sport, requires appropriate infrastructure, organizes and validates what you do to your C-suite, allows you to go to the C-suite, ask for more infrastructure or items that are needed, in our case, some were FTEs. It is a way to assist coordination of vascular care, and I'm not going to go through the rest. Dr. Darling has already done that. As far as branding, you did receive through the SVS this letter from Dr. Mills and Schutz outlining our branding campaign. We have used this as part of our own branding campaign, which includes not only at our signature line for all of our notes, for all the members of our section. You see our hospital there, but you also see the double diamond that Dr. Coe referred to. We've done a presentation on doximity on behalf of SVS and the verification program. In our hospital itself, we've put out flyers, we've put out banners to identify this to the patients that are coming in. We've also done presentations through LinkedIn. Again, this has been shown before, but I encourage all of you to go down this pathway and go down this journey with us. This is the meet and greet that Dr. Eagleton was referring to. That will be in the area directly behind us. I appreciate the time. If you have any questions, thank you.